Testing. So that I will be looking because then you'll have a lot over that. This is our front camera, but it's a 360 camera. So it's in the see you and the audience. And then also, as you can see, this is what we got here. That's us, that's him, that's the audience. So we get the great view of the main slide will be clicking through. We have a presentation mode if you'd like to. We have
Oh, no, we don't. She put it in anyway.
Okay.
And so we'll have to use for the get some video.
Yes.
I don't think what I was clear on. And then, so we already recording?
Yes.
Oh, we are recording. You edited it down. Okay.
Testing, 1, 2, 3.
Yeah, because I have a microphone.
Not for the room. Just for the Zoom. These don't connect into the room.
Explain to me.
So these are making sure that people on Zoom can hear you.
Yeah. Okay.
So this one's on mute. Which would you prefer? Because we only need one microphone now, correct?
Well, she'll be coming up shortly to speak.
Okay. So
Yeah,
the
one for now is good.
Okay. You prefer live or?
This one is better. I think that's.
Or we can.
Put the lab on. Yeah.
So you want to wear it off?
Yeah, you would wear the lab. But I won't be mic'd for the room, so that I need to project.
Yeah.
But I need to be careful not to be screaming at the people on.
It shouldn't get too loud.
Okay. Yeah. Oh, they can turn down their volume. Oh, you're much here. I can raise mine. I can probably raise mine so that we. Okay, I'm talking in the background. I'll shut it if it's spotlight. Okay, I am going to go ahead and get started. We're still getting a few technical things set up. It's great to see everybody. It's great to see that everyone. For my class made it over. So good afternoon. I'm so pleased to welcome all of you to today's panel discussion, providing health services and complex humanitarian emergencies. Welcome to the students in my Intro to Global Health class who are here with us, and also to all of those joining us from the Pitt community, as well as the larger community outside Pitt, both in person here on our Oakland campus and also on our Zoom link. I'm Cynthia Salter. I'm the interim director of the Pitt Center for Global Health, and I have the pleasure of moderating today's discussion with three. We did have one last minute person who was unable to make it today, with three remarkable individuals who will describe the work that they and their organizations carry out under extreme conditions around the world. Before introducing our panelists, I would like to say thank you to the sponsors of today's program, including the Global Studies Center and particularly Elaine Lynn, without whom this program could not have gotten off the ground. I'd like to thank the Center for Latin American Studies, the Center for Russian, East European, and Eurasian Studies, the University Center for International Studies, the Committee for the Pitt Public Health Emergency Preparedness Certificate, the Pitt Center for Global Health, and the University of Pittsburgh School of Public Health, as well as our wonderful Pitt Tech support team, which makes it possible for all of you in the audience to hear this important information. We could not have done this without all of your support. So complex humanitarian emergencies. This is a blanket term that includes natural disasters as well as civil unrest, open conflict, and other unstable conditions. In these situations, clinicians face potentially dangerous conditions as they provide critical physical and mental health services to people who are facing uncertain futures where authority and infrastructure have broken down. Our panelists today will describe their experiences during the complex humanitarian emergencies currently taking place in Haiti, Ukraine, and Gaza. I want to thank our panelists for joining us today. And we've given them an almost impossible task to describe their humanitarian work in just 10 minutes. So we will hear each of them condense an entire world of their passion and their compassion into a very brief overview so that we can better understand their work. After our 35 minutes of presentations, we'll have another 30 minutes for questions from the audience. I know that the students in the global health class will have to leave at 3:45 for other classes. So I do encourage you to ask your questions early on. The rest of us will have until 4 o'clock when we close the program. Now to our panelists and to introduce them. I'll keep my introductions also quite brief in the interest of all that we hope to cover in today's discussion. And I will introduce all three panelists and then each will present their work. And I would ask that you hold your questions until the very end when we'll have our discussion section. Our first panelist is Dr. Yvetot Joseph, joining us today via Zoom from Port-au-Prince, Haiti, where he is a clinical research coordinator, site coordinator. Born in Haiti, Dr. Joseph completed his medical training in orthopedics in a number of locations, including France and the US. He was a Fogarty Global Health Fellow at Vanderbilt University here in the US, and he will describe his ongoing work in Haiti, which, as you know, has a long history of facing a number of natural disasters and which is currently experiencing its worst humanitarian crisis in recent history. Our second panelist, joining us here on site in Oakland, is Dr. Carmen Adrescu, also an MD and a licensed psychiatrist. We're very happy to have her with us today. She's a professor of psychiatry here at Pitt, and she's director of the Argo Neuroscience of Aging Research Program. And she's an internationally recognized expert in the clinical treatment of late life anxiety and depression. Her research uses multimodal neuroimaging methods, behavioral measures, and ecological momentary assessments to integrate the neural basis of late life mood and anxiety disorders and their association with accelerated aging. She will describe her work with an international nonprofit foundation called Human Rights and Mental Health, working in the Ukraine since the Russian invasion and war there. Our final panelist, we originally had two, Dr. Zahir Salul, who will be unable to join us today, but Dr. Thair Ahmad will be joining us today from Chicago, also via Zoom. Both he and Dr. Salul work with Med Global, which is a nonprofit humanitarian organization committed to delivering crucial healthcare to populations affected by crisis and poverty worldwide. Dr. Ahmad is an emergency medical physician, also at Advocate Christ Medical Center in Chicago, and he's a clinical assistant professor at the University of Illinois at Chicago. He serves as the Global Health Director and the Assistant Director for the Emergency Medicine Residency Program at Advocate Christ. He has pursued additional training in health emergency and humanitarian response through programs at both Johns Hopkins and the Harvard Humanitarian Initiative. He's a Med Global board member and recently returned from Med Global short-term medical intervention in Khan Yunis, Gaza in January of this year, where open conflict continues today. Most recently, we have learned of the crisis at Al-Shifa Hospital, Gaza's largest hospital, where Israeli forces have just recently withdrawn, and we do see conflicting reports emerging about the situation there. So with that, I will turn our presentation over to Dr. Joseph, who is joining us via Zoom, who will talk with us about the situation in Haiti. Yeah. And Dr. Joseph, I will move move the slides for you. Just let me know whenever. Go ahead whenever you're ready.
Thank you, Dr. Salia, for this wonderful introduction. And good morning, everyone. Can you hear me? Before starting, just want to know if the sound is okay, everything's perfect.
Okay, let's try it again. Go ahead.
Okay, good morning to everyone. Can you hear me now?
Perfect. Much better.
Thank you, Dr. Saller, for this wonderful introduction. And good morning again. My name is Ifto Joseph, working in Haiti. Born in Haiti and live in this and trying to face this actual crisis in Haiti and trying to do our best for the well-being of our patients. So first slide, okay, thank you. Good morning to everyone. Would like to thank first Dr. Robert and Dr. Roman Nakayo for this invitation to present JSQ Haiti site in the actual crisis context. Thanks to the JSQ staff, particularly Dr. Pap, Dr. Deschamps, Dr. Joseph, and Dr. Uzi and Dr. Sever, and as well the JSQ patient for the trust on us. Next slide, please. The GSQ Centers is a Haitian non-governmental organization founded in 1982 to address burgeoning AIDS epidemic and is one of the oldest HIV/AIDS centers in the world. Its mission is to address public health issues affecting Haitians to improve access to care for the most vulnerable. And the three pillars of GSQ's mission are conduct translational research, training, and provide quality clinical care for infectious and non-communicable diseases. Beyond immediate medical care, GSQ also organizes services and a comprehensive model of care to support the whole family with a primary school located on the same campus, serving the local community, including patients followed at the center, a vocational training center, and economical support opportunities. Next, please. The crisis in Haiti can be briefly described by four words. It's chronic, severe, multidimensional, and evolutive. From 2019 to 2021, there were massive protests calling for the government at that time to resign. And on July 7, 2021, the president was assassinated. On March 2020, we had the first case of COVID. And March 2021, Haiti succeeded major wave of COVID-19. On August 14, 2021, the South Department were hit by an earthquake. More than 2,000 people died and more than 13,000 people were injured. In September 2022, a federation of gangs created and blockaded around Haiti's largest fuel depot, combined with an outbreak of cholera. In 2024, this year, we already have more than 1,000 people killed by gang violence, and Haiti's gangs wars have intensified in recent weeks, including raids on police station and the international airport, which is remained closed since March. Next. In this slide, this is the metropolitan area of Port-au-Prince, where over 200 gangs are active. All red, blue, and purple point where gangs are active. The multi-cent and the Canadian cross is to show where national roads are blocked by gangs. Next. The gesture contingency plan has been in place since 2000, and its goal is to maintain services and research in case of social, political turmoil, and natural catastrophes. The contingency plan is revised and improved after each new challenge. The main strategies include constant communication with staff, patient and research participants, secure safe housing for staff living in dangerous neighborhoods or forced to abandon their homes, have additional locations where participants can be seen when security concerned in one area, offer lodging close to JSQ for DOT in case participants live in an insecure area, remote access to our EMR, and research data entry platform. Next. One of the most important things is to know that the JSQ Community Advisory Board and JSQ Community Health Department established respectively in 1997 and 2010, also assist in mitigation procedures with the community to ensure the conduct of the research. Next. The GESCO leadership model is based on responsibilities, resilience, persistence, and planning for the worst scenario. As a provision of global health, we have to provide free comprehensive healthcare, transportation fee, phone call, home visit, nutritional support, and also the staff organization is based on communication, flexibilities, and the organization of activities is planned on anticipation. So we have to plan alternative visits for procedures, for example, and for the structural modification, we have to, for example, staff shuttle and carpooling. In case of fuel rationing, in order to prioritize unit essential to research, for example, laboratory, research pharmacy, data management department. Next. In order to have additional location where participants can be seen, GESCO has established community care centers in the metropolitan area. With efficacy and efficiency, we do provide ongoing training for community staff, including nurses and field workers. Locate community centers in areas where patients live or in areas of high HIV prevalence and ensure these community centers are operational. And the objective of monitoring and evaluation, M&E, each site is supervised and improved according to the weakness and needs. Next. So this is the same picture that we showed previously, but in this slide, we will show you all yellow point in the picture. This is where the community centers are located and operational, and we have a total of 10 community centers. The big black and the big blue point, this is the main two sides of GESCO, and the big blue point, the IMIS, yes, this is where I am actually to present you this presentation. Next, please.
Oh, I think that was the last slide that we had room for. I wanted to give you an opportunity to sum up the experience with the community centers and close out to move to our next presenter. Final words that you'd like to add?
Okay. So and Haiti experiences the worst humanitarian crisis in recent history, and GESCO long experience and overcoming challenges has enabled it to maintain excellence in clinical research, continue to expand its participation in various international networks, and contribute to the evaluation of solutions for public health problems affecting the population. And the strategy is essential.
Oh, okay. So we have you on the screen, but can we still hear?
My name is.
Can you still hear us?
Can you hear?
Yes, yes, I'm here.
Oh, okay. I'm sorry. We momentarily couldn't hear you. Did we miss the last piece of your closing? Hello?
Yes.
Oh, okay. Okay. Did you have anything else you wanted to add? I apologize. We had some technical difficulties here. Did you have any last things you wanted to say before we moved forward?
We have to remember that after each new challenge, we have to update and, if necessary, change strategies in order to maintain the quality of service. And know that new challenge will need new mitigation in order to face with and to have solutions and to go on and to still maintain the good quality of care and for the well-being of for our patient. For retention strategies, though, we improve patient reception, improve the provider-patient relationship, reduce waiting time, and provide same-day test and treat. provide multi-month distribution ART drugs, and before each visit, we do perform systematic phone call as reminder for the patient, home visit upon enrollment, geolocation, and follow-up.
Okay, thank you. Thank you very much. I'd like to give a round of applause to Dr. Joseph. We will be coming to you with questions for when we have gone through our other presentations. How can I get the PowerPoint back up again now? So now we'll turn to our on-site guest at this point, Dr. Carmen Andreescu, who will talk about work with the mental health nonprofit organization in Ukraine. Like to advance? Sure. Or I can advance for you.
I definitely can.
I have to go through all, I have to go through all 15.
You do?
There, thanks.
So this is it.
Yep.
Do I need to use this or yeah?
No, you.
Oh yeah, I have it. Okay. Good afternoon, everybody. Beautiful spring we have in Pittsburgh. I'm going to talk briefly, and I'll spend most of the time hopefully answering your questions. The organization that I'm part of is called Global Initiative on Psychiatry, and it became involved very fast in providing mental health relief in Ukraine. This is the landing page of the organization. It basically started, and this is important for understanding the framework. It started from observations in the 1970s when the Soviet authorities, they were doing it even before, but they got bolder and bolder, and they were labeling political dissidents as psychiatrically ill. They even invented a mental disorder for them specifically. And they ended up for years and years in long-term psychiatric facilities, receiving high doses of antipsychotics and so on and so forth. One of the people at that point who managed to get some information outside of the Soviet Union, which by itself wasn't an easy task to do, got in touch with some Dutch people your age, and a few of them decided that they want to verify this. And one of them, called Robert van Voren, he went as a tourist to the Soviet Union. He went to Ukraine, and that's where things start to tie up. And he connected there with a young psychiatrist, not me, this was in the 70s, who decided to gather information about this political abuse. And several times in the late 70s, early 80s, Robert went back and forth to the Soviet Union, getting hard evidence about this political abuse of psychiatry in the Soviet Union. And that information was crucial for excluding the Soviet Psychiatric Association from the World Psychiatric Association. And then in the late 80s, when Gorbachev tried to reform things, and early 90s, when there was no longer a communist government, they decided to call a Western Western group of mental health reformers to help. Why am I telling you this story? Is because the psychiatrist that Robert made contact with in Ukraine was caught by the authorities. He spent 10 years in the Gulag. And when Russia invaded 2 years ago, he was the president of the Ukrainian Psychiatric Association. The two of them were going back so many decades. So they knew each other. They already were working for many years on various other things. So when the war started, the Global Initiative on Psychiatry, which is the organization this group of young Dutch people put together, and then that spread throughout the world, didn't stay just in the former Soviet Union. They had a good infrastructure in order to work with. They had good information on the ground about what was going on, where things were needed, and what things were needed. And I met them, both of them, in the mid-90s. I left Romania in 2002. Until that point, I was involved with efforts to modernize mental health system in Eastern Europe. And after I came here, I maintained contact with them. They had, as you can see here, they had all these organizations in different parts of the world, such as sisters or daughters organizations, how you want to call them, including Sri Lanka, for example. They had one in China trying to deal with the Falun Gong sect, if you guys know that story, which the communist authorities in China tried to also label as mentally ill. And they also had here, let's see, a small organization, which initially they wanted to use to launch some effort to reform the penitentiary mental health system in the US. That didn't go anywhere. But that was enough that we had the legal framework to start using the US as a base. As I was saying, I am not the one on the ground. I am the one in the US, basically screaming at people for money, okay? And telling them what we need that money for. And a few times I went to Eastern Europe, I talked with them, I saw what they were doing with the funds that we raised for them. This is our current landing page on the American website. And some of the things, so this is Ukraine, obviously. Some of the things that we've done at the beginning of the war, as you probably are very much aware, I don't want to lecture you about things like this. The Russian army entered through various front lines, very close here to Kiev and to this place here called Chernihiv. The Ukrainian mental health system is pretty old, fossilized, kind of like asylums with thousands and thousands of people that are living in there with what they call social homes, which are the equivalent of nursing homes or personal care homes. And what we've noticed is, for example, able people, young people left the country or were displaced in the West, and a lot of people in the East remained there. Either they were stuck, they had no means, or they were in these big social homes. And at some point, the Russians started to target the electrical grid. And all our, attempts to do just, we're going to bring them medications and we're going to bring them other things that they may need from one day to the next. We had to switch everything, for example, and start gathering funds to buy huge generators to keep these places from freezing up, because the Ukrainian winter is the Russian winter, it's not the Pittsburgh winter. So that was part of our effort last year. This year, these are some of the people, the local people that we worked with. So we have people on the ground who know very well what's needed. And our advantage was that we had a long-term collaboration with them. What they didn't have, obviously, were funds to always, adjust to the immediate needs, because Russians were very creative in the kind of damage that they were doing. And we couldn't stay with, this is our plan. We're just going to send everybody, I don't know how many boxes of medications or like headlamps, for example, or something. We had to adjust to everything that was happening from 1 month to the next. We also created this large platform, online platform that people could access, where they could get in touch with therapists to discuss about their trauma. I have a long list of stories that border on, not border, they're pretty horror stories about what people were accessing the platform for, but they were talking with someone who had expertise in helping, at least for the acute phases of post-traumatic stress. And we also created this crisis center because a lot of the refugees ended up in the Baltic states and in Poland. This is in one of the Baltic states with psychiatrists and nurses from Mariupol. And they, the refugees were the lucky ones, kind of, okay? They were the ones who were, let's say, physically more or less intact. So everybody say, well, we're going to deal with the ones who are still in the country. And we decided to do both. For the refugees, the kind of mental health efforts have to be tailored in a different way. For the ones who are staying in the country, it's very hard to try and, so let's say, help with an ongoing trauma. Every, psychiatrist worth his or her salt will tell you that until you extract them from there, you basically just pouring water in a bottomless bucket. So another thing that we're doing now, I don't know if we have that here. This is an example of a social home after the Russian army went by. This was a home of, I don't know how many hundreds of old folks. Another thing that we're trying to do now is to put together a center for veterans' mental health. As you may know from the US too, veterans have an extremely high rate of post-traumatic stress, and they also get a very high rate of, let's say, legal difficulties, economic difficulties, family-related difficulties. So we're trying to intervene before these people end up in situations that, before they ruin their lives, the lives of those around them, actually their lives have been ruined by someone else, not by themselves. Don't. I also have a 2-minute video that I think you guys should see. It's from a larger movie that has been done in that little place I showed you, Chernihiv, after the Russian army was pushed back. One of our collaborators went in this big asylum and filmed around. People were still living in the basement where the nurses and the doctors were all together. They had to make a makeshift cemetery because they had snipers who were like, I don't know, targeting them. And probably one of the stories that stayed with me for a long time was that the doctor had to put on her white coat every time they wanted to bury someone, hoping that if the snipers see the white coat, they're not going to shoot at them. Do it, I don't touch it. It has sound, but Thank you. That's instead of my last words.
Oh, thank you very much for sharing that. Thank you for your presentation and for bringing us this film. Okay, we have a final presenter who will talk about his most recent work. And then before we open up to questions, we have Dr. Thayer Ahmad, who is joining us via Zoom as well.
Hello, everyone. Hope everybody can hear me clearly.
Yes, we can. Welcome.
Thank you. Thank you for having me. It was supposed to be me and Dr. Zahir Sahlul, who is the president of Med Global, the nonprofit medical humanitarian NGO. But he unfortunately had a last second emergency that he had to attend to, so it'll just be me. But I do wanted to just kind of give a brief outline just with respect to what our organization does. If we can go to the next slide here. And then the next slide, sorry. So, this is an organization that works in several different countries. We work in Ukraine, Yemen, Sudan, with the Rohingya refugees in Bangladesh, in Gaza, as well as in the border between Mexico and the United States, Guatemala, Venezuela, and Colombia. And sort of the idea of this organization is to be able to strengthen local healthcare worker capacity, not really kind of a drop in and drop out sort of approach. And part of what we've seen with these very complex humanitarian emergencies is it's a lot of what you do gets is on the fly. You have to learn about it last second. There isn't a lot of things that can be done pre-planning wise, especially with respect to some of the conflict areas that we've been in. And oftentimes the center of where you're trying to deliver care, oftentimes those areas can be attacked. You're dealing with mass casualty event. Mass casualty event is generally defined as a large group of trauma patients greater than 7 arriving and utilizing resources at the same time. There is always concerns with respect to water and sanitation, to food security, to the ability to have consistent access to telecommunications. And then there's displacement, which is what we've seen in conflicts take place over the last several decades. Is there's a massive forced displacement of people that burdens that adds this sort of additional burden to a crisis that may involve conflict. And then, of course, there's the lack of attention to non-communicable diseases, and then the spread of communicable diseases. All of this in the backdrop of ongoing and recurrent trauma. Can we see the next slide, please? Of course, everybody has to figure out how they're going to approach it. And I think you have to get comfortable with this idea of being able to deal with limited resources and just not be able to necessarily have all of the tools that you need. Now, this requires flexibility, it requires resilience, it requires being able to be adaptive. You're not going to be able to control the environment that you're dealing with. Next slide. I wanted to bring up, this is kind of a moment of ours. This is Dr. John Kaler. He's a co-founder of Med Global. He's a retired pediatrician. This picture is actually from a primary health clinic in Rafah, which is the southernmost tip of the Gaza Strip. This clinic was opened up by Med Global, given that there was a massive amount of people in the Gaza Strip who were displaced to the south. Now, the Gaza Strip is a really small strip of land. It's about 25 miles long, 5 miles wide, so less than the length of a marathon. And a lot of the people in the north of the Gaza Strip have been forcibly displaced to the south, particularly to Rafah. Rafah is the southern edge of the Gaza Strip. It borders with Egypt. There's a large border wall. And so anytime you go there, what you'll see is you will see that there are tents everywhere, that the shelters are over capacity. And we have a primary health clinic that we opened up and we were seeing 700 patients a day. And Dr. John is explaining to us that, what happens is what you'll see is many diarrheal illnesses will spread amongst the kids in all of these camps. And then they'll show up and they'll be dehydrated and they will there will be this cycle because they're not able to have adequate water, not adequate access to food. So the dehydration gets worse and the kids get sicker. And then this becomes a massive burden on an already overstretched healthcare system. So that's, this is an example of a child that he was examining. Can we see the next slide? So how do you, we were able to open up a primary health center in Gaza, in the center of where there was many displaced people. These pictures are actually from Syria. And this was something that the Assad regime had tried to, one of the first things that they did is they were targeting healthcare institutions and infrastructure. And the thought was that if the hospitals are destroyed and the doctors are gone, then the people will leave. And we found that to be mostly true, that people, if there's no access to care, if there's no access to NGOs or humanitarian aid organizations, if it's not reasonable, they will move to a spot where they can have that access. I mean, at the end of the day, it's important for people to be able to survive and to protect the nucleus of their families. And that's something that we noticed in Syria came under attack. And so as a result of this, what you're looking at are hospitals and clinics that are open underground and or buried within mountains, and just trying to essentially be able to figure out how you're going to serve a community or a population within a given area while also avoiding the imminent threat of attack. Next slide. So, what can we provide to the situation? What we found most of the time is that local healthcare workers are the best people to be treating the local population. I mean, they know the people the best, they understand the culture, they speak the language, they understand the nuance and the context, and an idea of sort of parachuting in as a foreign medical doctor is not going to be the best remedy. In fact, there may be some gaps there that you're not able to address. So what we've tried to at least address, or what we try to do as an organization, is how can we best serve that local healthcare force? I mean, is it through training? Is it equipment? Is it security? Is it supplies? And that's something that we like to do. And one of the pictures up here is the portable ultrasound, the butterfly. And this is something that you're able to plug into a smartphone or into a tablet. And what we found is that the providers in many of the conflict areas in Syria and in Gaza especially were very keen on becoming facile with this modality. And we were better off sending people who could train 2 or 3 champions of the technology, and they would train other doctors, other physicians, and then they can serve the patients. And this is kind of like a low, this is excellent to use in a low resource setting because it doesn't require a lot of maintenance support. It's not prohibitively expensive, basically, to be able to transport these things in. Next slide. Obviously this, with things evolving and the landscape changing, I mean, I think COVID taught all of us that maybe, there is a possibility that restriction of movement can impact the way you're able to deliver and reach beneficiaries. And so trying to figure out what are the best practices with respect to telemedicine. I think we're seeing a lot of that now. I don't think it's in a place yet where it's rolled out as well as some people would like. However, I think that there are opportunities there to be able to support local healthcare workers in different areas. And we talked kind of about the portable ultrasound. I think finally, really, the other thing is how also can we help the professional development of local healthcare workers? There is a clear appetite for healthcare providers to continue to develop themselves professionally, to gain additional training, to be a part of international workshops and courses. We can play a role in kind of supporting that and sponsoring that, and really just trying to meet the needs of healthcare workers. Next slide. This is images again from Syria, just kind of in these makeshift sort of infrastructure that you're able to put up, and just trying to illustrate that some of these patients that you see, I mean, some of these areas look like they were formerly kitchens, bedrooms. Next slide. Next slide. The other thought is that with respect to, when it comes to humanitarian aid and relief and medical work, there is this circle, there's this synergy that sort of exists, or this ecosystem between all aspects of humanitarian aid, things that you might not necessarily consider. In Gaza, one of our biggest challenges is the fact that no diesel fuel has been able to enter into the Gaza Strip since October 7th. And that, the power plants that typically, or, the water desalination facilities that typically need power to function, to desalinate the water or to remove wastewater management, that those have essentially been compromised as a result of this war. And so it's important to keep in mind that it's not just about medicine and supplies and treating the wounded, but it's about making sure that there's adequate diesel fuel, that there is an opportunity to provide clean water, that there's sanitary services and sanitary products for the population, that there's access to safe spaces. So these are all things that are in line with what you have to be addressing. It's not just a trauma surgeon showing up. Next slide. Next slide. So, this is just kind of some thoughts with respect to how we want to, what some of the concerns are and how the new world that we live in has really started to change, how we practice and how we respond to disaster situations, to conflicts, international humanitarian law and its ability to be enforced. I mean, I think that's a challenge that we have in Gaza now. What are the mechanisms in place that we can make sure that healthcare systems are not necessarily targeted? How can we make sure that there isn't violations with respect to aid being restricted? How can we collaborate on the ground with different partners? Is there a way that we are able to measure the impact in a reliable and accurate way when access is limited? I think one of the things that came out of Gaza was that a lot of the information that we had to use and collect was based off of people's social media. Just being able, that if they were in the north of Gaza, for example, which is incredibly difficult to access, you're relying on people who are there and just kind of trying to piece together how it works. How does artificial intelligence start to play into all of this? That's something to consider. Can high fidelity simulation with virtual reality, can that be used to train local healthcare workers and medical students? And then, drones, can that be used to deliver aid and not just maybe deliver bombs and bullets? And then realizing that we have a role to play with respect to advocacy and trying to elevate some of the stories of the situation that's on the ground. I think what we found is that depending on how muddy a situation becomes and how there are so many different partners and positions at play and agendas there, how can humanitarian organizations sort of maintain medical neutrality, maintain impartiality and being unbiased, and advocate for sort of the ease of suffering, and for people to have the opportunity to at least have access to food, water, healthcare. So those are important things to consider. Next slide. Okay, I think there's one more. I think after this, there's a couple of slides. Just want to double check. No, okay, got it.
I may not have those. I apologize. I may not.
No, that's
have
okay.
those.
There was just pictures, but that's fine. Yeah.
But final words to close out for your section before we move into the question and answer.
Yeah. So I mean, I wanted to just sort of briefly share. We were just in the Gaza Strip. We had a team there just show up last week. I was there in January, and I just wanted to sort of share how there was a significant struggle in terms of getting in terms of securing the safety of our staff that's on the ground, the locals that are on the ground, as well as the people who are coming internationally. There was concern about establishing telecommunications, concern about actually being able to bring in the aid that we had procured. And it's one of the most challenging things that our organization has had to deal with. And I think coming out of this, it's underscored the importance for us to be able to collaborate with multiple groups, organizations, governments, NGOs, as well as continue to make sure that you are effectively documenting what's taking place. You are making sure that the data that you have is not just writhing away on some USB disk, and just making sure that you're able to in real time make decisions that can help ease some of the pain that's on the ground. So thank you.
Okay, we have some time that I would like to open up the forum here to